시청자 여러분 안녕하세요.
Hello, everyone. My name is Kim Se-jin. I'm the new MC of the case discussion. The case discussion is my favorite program, and it is my honor to be the MC of this program, and I'll do my best to facilitate the discussion. Today we have Dr. Kim Kyung-won, Professor Kim Young-taek, and Dr. Park Jong-hyun. Hello. I will try to do my best to play my role as smoothly as possible. We will discuss the case for the discussion. For those who are watching then all TV, on the right-hand side of the video player, you will find the real-time chatting window to post the questions to us and share comments. Today's case, 76-year-old male, PMH includes arrhythmia and prostatic hypertrophy. Number 46 was extracted in August 2020 in another clinic. The story goes, number 46 is planned to have implant placement. Number 45 has 2 mm mobility. That will be extracted first. And is it good to place 45 and 46 together? If I place implant at 46, what do I need to be careful about? How much improvement can I expect there? Number 45 doesn't have very good CR ratio if it is not extracted. How can I maintain number 46 after implant placement? What do you think? Looking at this case, I don't do a lot of perio treatment. I would recommend the extraction of number 45 to make it an easy case. Looking at this case, I am in the periodontal department. From periodontal perspective, I realize there are so many challenging cases. I will talk about this, listening to our colleague doctors. With you, the audience, I'll try to come up with a good solution. I'm not a perio expert. Sometimes I tend to listen to our patient's opinion, but the outcome is not really good. As Dr. Kim Kyung-won said, I will choose to extract. Let's talk about the case by taking turns. Dr. Park Jong-hyun, would you go first? I have brought with me very basic cases commonly treated by private practitioners who are not periodontal experts. It may have some mistakes. In 2015, the patient came to me. Periodontitis is observed. These teeth have intermediate level mobility. These teeth could be saved with the perio treatment, but I didn't want to place implants in the edentulous region. With the consent of the patient, I extracted them and implant restoration was done. The patient came back this week. 6 years later, everything looked okay except number 34. It has mobility and occlusion is stable. Trusting the posterior occlusion to extrude number 34, the occlusal surface is aggressively reduced, and a perio treatment is also given. Today, in 2 days, the tooth is extruded. This means the tooth was under heavy stress to be extruded like that in 2 days. The treatment is based on this book titled Bone Leveling Saving Teeth. I read the book in 1915. It was so interesting that I gifted this book to my advising professor. Briefly, it talks about erupting tooth, bone filling up, CR ratio improvement to boot. If I may elaborate on it a little bit more, periodontal pocket is the cause of tooth eruption, and the pocket will disappear because of the eruption. That's the physiology of human body. In October 2019, a patient came to me. Root canal treatment was done in another clinic. Many dentists advised him to extract the tooth, but he didn't want it, so I decided to respect his wish. MB root was severed, and the occlusal plane was reduced. 1 year later, 14 months later, inflammation disappeared, the tooth erupted, and the bone filled up. I believe the environment has improved for the implant to be placed later. Did you do the crown? No. I recommended the extraction. I absolutely do not recommend to use this treatment. For root rejection, I use the procedure often. Dr. Kim Young-taek, what would you do? I would extract too. I would recommend to extract the tooth. I wanted to extract the tooth, but patient did not accept that. Anyway, it is maintained for 14 months. I don't think the tooth would be helpful for chewing. It is not involved in the function. But I just wanted to respect the wish of the patient, and the environment has improved for later implant placement. You cut the MB root very nicely. When I tried, I end up cutting the crown too. Yes, I can do it very well. Let's go to the next case. I and the patient never thought about extracting the distal tooth. Now I think it could have been a better idea. After 4 years and 9 months, if it was extracted, I believe this could have been more stable. Now it's 4 years and 9 months later. Still, I could not extract that. I'm still treating it in terms of the periodontal treatment. If I extracted it before, it could have been much better. This is a very difficult case. I did it in 2016. I like to place one body fixture in narrow reach. 3.6 millimeter diameter one body implant was placed. Distally, a posterior step was made with an SS fixture. 5-year recall, it looks okay, but the patient really hates me. The patient is complaining about mesial and distal food impaction. The satisfaction on the part of the patient is very low. I did the relining twice on the adjacent tooth. Maybe I should have extracted number 35, or I think maybe I should have done a bridge over 34 and 35 and implant in the posterior region only. What do you think, Professor Kim Young-taek? That's a common case. It depends on initial mobility, if there was mobility or not. If there was mobility, 4, 6, 7 would be treated as a unit. And I believe I recommended extraction too, if there is mobility, but we cannot do whatever we want. We need to respect what the patient wants. But when we make some suggestion, we can say later, I told you so. Therefore, it is not a bad idea to give various options to the patient. Let's go to the next example. Post-crown can be the option. Implant was suggested after extraction. This is not like the previous case. The patient never complained for 4 years. The patient was very happy, and I realized extraction can help quite a lot. This is a common case. The tooth was mobile, and everybody agrees to extract it. However, the patient doesn't want to extract it. If it is not extracted, a problem will occur. Expecting the problem, at number 15, cantilever is used. 2 years later, I found the bone filled up the space, so there's no need to do cantilever if we wait. The problem occurs here. Number 14, I was hesitating whether to extract or not. If it was extracted 2 years before, it could have been much easier. So when we are hesitating whether to extract or not, if we decide not to extract, the patient satisfaction would go down later. Very narrow ridge in this case. The tooth mesial to the space where implant will be placed is mobile. Ridge splitting is done. 2 SS implants were placed in the posterior region. The problem occurred here. Number 35, I suggested occlusal adjustment so that perio problem can be relieved. And I told the patient the tooth can get sensitive, so the patient rejected that suggestion. I'm still thinking if I did the occlusal adjustment, the tooth would have been more stable. This is a different case. The patient sometimes listens to me very well and sometimes not. I wanted to extract this tooth. Extraction is usually rejected by a patient. There is a mobility, but it was not extracted. The ridge is very narrow. Ridge splitting is done and additional bone grafting is done. I placed the implant far away from the periodontally compromised tooth, but the patient was more cooperative. I was allowed to reduce the occlusal plane to guide the extrusion. After the reduction, by securing the posterior stop, mobility stopped and PDL widening cleared up. The patients need to listen to the dentists very well. Looking at this patient, I recognize the concept of extrusion. The teeth were extracted 2 weeks before at another clinic, and I just did bone grafting. I kept reducing the canine to induce extrusion. Did you do the bone leveling? Yes. At the beginning, there was a big difference in the height. Bone graft is done and implant was placed. Now it became like this. Over time, within months, the distal bone of canine filled up beyond the grafted bone. Much more than the grafted bone grew. 5-year recall. The bone formation has been achieved greatly. I don't think this is only due to bone graft. The canine was continuously reduced for extrusion and the grafted bone was pulled up together. With the posterior support, number 33, mobility is reduced and PDL widening disappeared. It is greatly extruded, so the canine and the lateral are almost the same. This is a worrisome patient. I strongly recommended extraction, which was rejected by the patient. So all I could do was placing an implant away from that tooth and induce the extrusion. The result of extrusion, the distal bone is formed and stabilized. Implant can be effectively placed there with good bone after cutting the cantilever. I think it was a good thing to listen to the patient. Come to think of it now, in the previous cases, even though I recommended extraction, the patient rejected that. So if you look at here, I should listen to the patients more carefully. Similar case, I never extract a tooth with mobility 1. If you secure the posterior stop, it'll be okay. I waited. There was bone resorption, and the bone was not formed after 3.5 months. So GBR is done to make buccal bone to place an implant, and the posterior stop was insured. We need to be careful here. When there is a spacing, number 4 has a spacing with number 3. You need to adjust the contact very carefully, otherwise mesial tooth would push up. Contact adjustment not to affect the adjacent tooth is very challenging, so I make rather strong contact, and if the tooth moves, I adjust the occlusion. So after the occlusion adjustment, the PDL widening is completely cleared and the mobility is gone. Now I want to talk about the key point. Implant infraocclusion, they cannot resolve TFO of residual teeth. If you place an implant very properly, if infraocclusion occurs, it doesn't help TFO resolution. I don't give temporaries in all cases, but I make sure a temporary is used when an implant's antagonist is also an implant. That is because when temporary is used for a month, I don't really believe the temporary would lower the occlusion, but I wait as long as possible for CR stabilization. After implant placement, sometimes we experience the lowered occlusion. I believe when a prosthesis is fabricated after using a temporary, the incidence of infraocclusion is much lower. External with a vertical stop or tissue level fixtures can be used without using a temporary. Even though we use such implants, I use a temporary at least on one side until CR is stabilized. Waiting until CR stabilization makes a difference in terms of the infraocclusion. When an implant's antagonist is also an implant, you need to use a temporary. I do bone leveling to induce extrusion. If you just make a prosthesis and do the bone leveling, the contact loss is bound to happen. I believe a temporary should be used when an implant's antagonist is also an implant. May I ask a question? How much does it cost? I don't know whether I can ask this question. Additional temporary would cost money. How do you address that? The temporary should be provided for free. I'm at a general hospital, so I'm concerned about the fee. Thank you. I understand. Regarding the infraocclusion, I had to remake prosthesis twice. Not necessarily because of the infraocclusion. When the prosthesis arrived, I found the occlusion was rather low. I talked about this with the lab, and they suggested adding porcelain to heighten the occlusion. I don't think that was a good choice. There is room for porcelain fracture. Contact loss can be addressed with porcelain adding. Infraocclusion can be addressed only by remaking the prosthesis. That should be remade to stabilize the remaining teeth. Summary: many teeth are mobile. When I place an implant, I try to place it along the long axis for prosthesis. This requires GBR, but I'm not skilled at it, so I don't do it. When a narrow fixture is lingually placed, it is prosthetically unfavorable, so I don't do it either. So when the ridge is narrow, I do ridge splitting to make a favorable environment to place an implant, and the final prosthesis is delivered. Stable posterior prosthesis is delivered. Posterior support is secured through bone leveling. The overall mobility was decreased. One thing I want to point out here is that when patients, just like the case under discussion, do not want extraction, I recommend a bridge. So cutting a bridge is not a big deal when the teeth need to be extracted. Number 7, extracting that is not a bad idea. So PFM bridge can be recommended, which is cheap if the patient doesn't want extraction. When the bridge fails, we can place implants. If the adjacent tooth is mobile and the perio problem is expected to get worse, single implant is a contraindication. However, a bridge is not a contraindication. Summary: the answer to the case under discussion: when teeth are mobile, if there is no posterior support that can be done, I believe extracting number 45 is good. I believe it is important to place an implant along the long axis to reduce the prosthetic complications. After implant placement, if you do sufficient occlusal reduction, it will be different from case to case. You can induce extrusion by that way, but at 5-year recall, if I say it looks good on the X-ray, would the patient be satisfied? I don't think so. Food infection causes a lot of pain to the patient, and adding continuously on the contact surface is not a good idea. So extraction is the answer. We need to be careful not to make implant infraocclusion. Otherwise, it can influence the stability of the residual teeth, and we need to check that frequently. Thank you. Thank you very much. Dr. Kim Kyung-won, would you like to introduce your case, please? Thank you very much, Dr. Park. And I'm impressed by his ridge splitting. Thank you. Ridge splitting, considering prosthesis. Looking at Dr. Park's case, I thought about this case. 56-year-old male. About 15 years ago, in 2005, he visited. Teeth were extracted in lower posterior, and he wanted the implant. In quadrant 1, maxilla, number 16 is missing. Number 15 is mobile, and I told him to extract that. He doesn't want the extraction of number 17 when I suggested it, and he really doesn't want to extract that because he lost too many teeth, and it is not very mobile as it is in the posterior region. I was thinking about the sinus graft there. As Dr. Park said, after prosthesis, food infection can occur. In this patient, if you look at the CT, at the time, it was a medical CT before the era of cone beam CT. From the lower left posterior, implants were placed. As I said before, number 15 is extracted and implant is placed in the upper posterior. In this case, as Dr. Park talked about sink down, these days TS-type implant is widely used, but in this patient I used only tissue level SS implants. I placed 3 in the mandible. At the time, I always mixed autogenous bone in the bone graft in the sinus. From the front of ramus using a trephine burr, the bone is taken and the bone is particulated and mixed with the bovine bone for the sinus graft. If you see here, the patient came for the first time in June 2005, and in July, bilateral posterior regions, tissue level SS type implants, very long ones, 13 millimeters, were placed. I had to act like an acrobat as I had to place long implants near the nerve, checking constantly the CT images. On the X-ray, after about 2 years, as I was concerned about, around number 7, food impaction occurred, and it was not very good. Initially, I recommended extraction. After about 3 years, 2008, it was eventually extracted. So number 17 was extracted. Number 16, the bone is resorbed, but the patient didn't feel any discomfort. Therefore, I didn't treat it any further. After 8 years, the other side created a problem. So this is the follow-up images. At that time, the patient said clinically he could live with that. After 13 years, the natural teeth were extracted in the upper left posterior, and it was hard for him to chew. Therefore, he wanted to place one implant on the right side. In 2018, 13 years later, in the upper left region, we used the casket. Using a crystal approach, the implant was placed, and the patient was lost to follow-up, and then came back in 2020, April last year, after about 15 years, and I took the images in the upper right posterior. Autogenous bone is mixed in the bone graft in the sinus, and bone is remodeled there. So there's bone in the posterior region, and I thought the implant can be removed and another implant can be placed. The flap was opened. All the surface of the implant at number 16 was exposed, so it was rather easily removed. The probe depth was okay, so using bovine bone, graft was done. And SS implant is placed at 16, and number 17 is drilled. I didn't do anything like a crystal approach. 15 years ago, the bone graft material was inserted with autogenous bone, so a small graft is inserted in the drilling hole. The implant is placed. About 11 months later, the prosthesis is completed using the bone graft done 15 years before. The implant was placed. All tissue-level implants are used here. In the lower posterior, you can see they are very well maintained. These days, so many dentists insist on TS-type implants, and I could find this case where only SS-type implants are used. Looking at this case, if I extracted the tooth from the beginning, I might have had better prognosis for the sinus graft. Recently, many dentists think sinus surgery can be done without bone graft. But if you open the place, if you do the graft, later, like 15 years later, you can place implant still. Professor Kim Young-taek, please. Okay. Dentist sent us this question because he has some experience. If you look at 45, the clinical picture shows it's very clean. So there's a 2 millimeter mobility there. It means the distal tooth is periodontally compromised. So with the perio treatment, it can get better and the bone is okay. But still, the dentist sent us this case to us to discuss because he may have experienced the TFO problem in the mesial tooth when implant is placed. If you look at this case, chief complaint is about 45 and 46. The mobility is 2 for 45 and probing depth is 6 millimeters. There's angular defect, the PDL spacing widening. Crown root ratio is bigger than 1. On angular defect means that there is TFO problem, so does PDL space widening. There's a perio problem, so angular defect occurred with worsened CR ratio. So this is secondary TFO. There is a perio problem due to bite force or external force. TFO occurred. You will remember what you learned at school days. It is not solely due to the force, but periodontal disease was there. Therefore, treatment can be done for the perio problem. However, TFO can increase due to implant placement. The traumatic occlusion, due to the traumatic occlusion, tooth can be lost one by one, and an implant can be placed in its place. This can be good for private practitioners, but it is not so good for the patients. Therefore, we need to have a comprehensive understanding of that. Let me explain the traumatic occlusion. Number 36. Due to endofailure, it was extracted. Implants were placed using GBR. After 4 months, healing abutments were connected. Final prostheses were delivered after 2 months. The process, surgery and second surgery period test value was pretty good, no problem up to here. But problem began to occur, screw loosening, implant crown fracture. After number 36 implant is placed, number 35 began to have problem, mobility, chewing difficulties, even though the probing depth is normal. That's a typical traumatic occlusion. If you use articulation paper for lateral guidance, it looks like the problem is number 35. All the maxillary teeth crowns are connected, so more force was applied, fracturing number 36 porcelain, and the screw was loosened because of that. Screw loosening can occur more under lateral force. The teeth are worn down, the lingual cusp is high, and the guidance interference is observed there. That's the problem. If you look at the tooth behind the implant, we don't incline the cusp very much. Because of this, the unwanted force, TFO, can happen. As other doctors said, due to implant sinking, the tooth is subject to unwanted force. So the tooth is higher on the X-ray, which is not really significant. These are my patients on the right. The mesial tooth of the implant shows conspicuous PDL widening and mobility, sometimes horizontal fracture. There can be many reasons. To confirm the causes of the problem, I look through my patients. I wrote a paper and published it. A mean follow-up of 5 years. I looked at the patients who have been with us for a long time. I looked at the premolars when implants are placed in molars, clinical pictures and x-rays. I defined the TFO and incidence of TFO. if you look at the significant factors causing the incidence of traumatic occlusion, splinted crowns before and after premolars compared to mandible maxilla had more significant incidence. I thought male would have more incidence, but that was not the case. It was not significant. When opposing tooth is an implant, the incidence is more significantly higher, and in premolars as well. Those are something I expected. I looked at the significance statistically. Splinted implants in the molar region, and implants are present in the opposing teeth. So it was published in 2015 or 16. People were aware of TFO. Still now, it is difficult to define TFO. Papers talk about TFO, but not many papers talk about the definition. Implant occlusal concept. When we learned in the school days, osseointegrated implant is not the same as natural teeth with PDL, so occlusal concept should be different from the natural teeth, but we focus on the survival of implant. So the occlusion applied to implants is designed to reduce the occlusal force during non-axial loading conditions. Now it is changed a little bit. Still, I've never seen higher cusp. But now we don't make it low, but sinking occurs. Now TFO continues. Prosthodontist, what is the concept of TFO in making prosthesis? Continuous sinking. My view is it is very important how you take impression. If you take a fixture level impression and deliver final prosthesis immediately, due to sink down, infraocclusion may occur. However, if you use a temporary for a sufficient time and you do retightening before fabricating prosthesis, I think infraocclusion due to sinking is negligible. When you take the impression, is it just normal impression taking on the abutment level? Yes. Or when you make it at the beginning on the tissue level as well. The concept is make it low. Most prosthodontists make it that way. I don't make a prosthesis so I can criticize them. I thought about various reasons and looked through papers. Sinking can be a problem. Some prosthodontists insist on using a temporary, and some reject the concept, and some just stick to SS-type implants and external type implants. Internal type is used in 95% of the cases throughout the world. That has very good benefits. That needs to be considered. And wrong fabrication of prosthesis can be the reason. Other causes, as molar area had been edentulous for a long time, the bite force in the molar area is 200 to 300, and at premolar it's a bit lower. So premolar acted like molar for chewing. So if you look at the case under discussion, the tooth was extracted not long ago, but the distal tooth is periodontally compromised, so that tooth may have been used. That can be the reason. Next, as I kept saying, the cusp inclination is too inclined. That can be the reason. Now, after identifying the causes, we need to address the problem after implants are placed. It's difficult to do that, but occlusal adjustments should be made continuously in the course of completing the occlusion. So this patient went through the occlusal adjustments. We achieved the occlusion like on the right. I think prosthodontists would know it better. I modify non-ideal occlusion. For example, when lateral guidance is on 4 or 5 instead of 3, I modified just slightly for those cases. Patients are resistive to reducing teeth, as Dr. Park said, but I tell the patients that they will lose the tooth if they do not agree with the reduction. Then they agree mostly. If you look at here, number 25, a vertical fracture, so it's extracted with a sinus lift. After prosthesis was delivered, about a year later, the patient complained discomfort at number 24. It's mostly they try to adapt, but number 25 and 24 couldn't adapt. So they begin to complain discomfort, chewing discomfort, mobility, and a little bit of percussion, but it is not really painful. And the probing depth is normal. This is a typical traumatic occlusion. If you look at the occlusal plane, the cusp of implant is not properly made. So in the picture, you can see how difficult it might have been for the patient. I took the video. I put the finger there, and you can feel that the tooth is moving alone. I put the finger to feel the movement, working, non-working, anterior guidance, all of those are checked. Like this, number 4, the buccal cusp is interfering. So there's high probability the problem is there. I don't use this quite often, but because I'm just doing perio treatment, I try to do it properly as I was aware of the videotaping. So it was reduced. Using the articulation paper, the distribution of force is checked. If you reduce it completely, the pulp can be exposed, so you need to know the limit, and this is done in multiple times. If it is okay, actually, in this patient, after 6 months, it became okay. If it is not okay, you need to repeat this process again and again. If you do it earlier, there are higher chances of saving the tooth. To answer the questions, after the implant is placed at 46, will TFO of 45 improve? Will the premolar become okay? Due to sinking or overload without occlusal adjustments, or until properly made prosthesis delivered, TFO will become worse. When number 46 is placed, the flap is opened, so you need to treat number 45, root planing. Probing depth 6 millimeters is indicated for flap OP. You need to record the probing depth to get the insurance coverage, and you need to do the scaling as pre-treatment, and you can do them together. After placing an implant at number 46, regular occlusal adjustments should be made. For the internal type, crown sinking is important, and lateral anterior guidance should be checked in the surrounding teeth. If number 3 is maintained, it's good, but this patient is 76 years old. Most old people lose canine guidance, so we need to note that. Here, implant needs to be placed. The possibility of extracting this tooth should be communicated, and it is important to maintain it with occlusal adjustments. Number 46 can be placed at the same time. Thank you. Thank you very much. Going back to the case under discussion, what would be your conclusion? Dr. Park first. Listening to the opinions of our colleague doctors, my concept has changed. I think various things, however, I'm still a bit lost. One thing is clear. When we place a single implant, it is not free from food compaction and it cannot satisfy the patient. Even though you show me very good 6 or 7 year follow-up images, I'm not sure whether the patient is really happy about it. Dr. Kim Kyung-won? I don't do prosthesis, so I don't know much about TFO, so it sounds more challenging. I would extract number 5 and that can be an easy solution. If we keep that, there are more things to consider. It's not an easy case. Dr. Kim Young-taek? I understand that clinically it's very challenging. We need to be aware of this. TFO can exist. Implant is a marvelous thing, and teeth are experiencing something new. TFO can occur, but we have neglected occlusion. We have been too much focused on implant placement, and we need to look around the surrounding teeth. We can extract the tooth, and the food compaction is really a serious problem. All of them are correct statements, but we need to consider this, and we need to broaden our views. To summarize what has been discussed, in this case, number 45 needs to be extracted to place implanted together. That is the way to reduce the complaint of a patient. If the patient doesn't agree to the extraction, we need to do the occlusal adjustments more aggressively to reduce the food impaction. So this concludes the case discussion. We talked about implant placement in an area with a traumatic occlusion. I would like to thank Dr. Kim Kyung-won, Professor Kim Young-taek, and Dr. Park Jong-hyun for the good advices. Thank you. I am Dr. Kim Se-jin. I'll see you next time. Thank you very much.
수고하셨습니다.